Welcome back to Coffee Talk with Mike and Janell. We are on episode 18. We'd like to have a discussion about hospitalization use with the IDDD population. The unfortunate reality is this population utilizes the ER in hospitals more frequently than their neurotypical peers, as does those who are diagnosed with autism spectrum disorder. There are actually 11% of children who've been hospitalized at least once before they turn an adult. So, Mike, I would like to discuss further what are the challenges, what are the benefits of someone presenting to the ER and possibly being hospitalized?
Yeah, so I mean, it's a really difficult conversation to have. When we started APEC, it started as a psychiatric emergency room hospital diversionary program. And that seemed to make sense to me. I mean, we're a child and adolescent psychiatrist trying to take care of kids in locations that we're not equipped to take care of them with. Kids with autism utilize hospitals more, as you just said, than their IDDD peers, and people with IDDD in general utilize hospitals and emergency rooms more than neurotypical peers. So to me, it was a no-brainer. To psychiatry, it was a no-brainer. Like we don't want people coming to the hospital for inappropriate reasons. When I first brought that topic up, it was really controversial. Families that we've presented in places where people are saying, why are you diverting hospitals? We need more hospitalizations. We need more access to acute psychiatric care. And families and individuals on the spectrum or with other developmental disabilities are 100% correct.
Yes.
They do need more access to this. There needs to be more locations and environments that we can do inpatient psychiatric care. But the reality of it is they don't exist really in this country. There's only a small group of neurobehavioral units throughout the entire country that specifically treat people on the spectrum or with other developmental disabilities. There's really only 2 in New York State, one for kids and one for adults. So the reality of it is there are a lot of challenges to utilizing acute psychiatric care for this population. Environments and training. The environments for our psychiatric emergency rooms or inpatient units for psychiatry are not built for the IDDD ASD population.
And they're typically very loud and chaotic.
With a lot of turnaround, with people with very different needs and challenges and strengths coming in, very verbal individuals. The staff aren't prepared for someone on the spectrum. They're not prepared for someone with an intellectual disability. Doesn't mean they don't make do, but they're just not equipped or trained for that purpose. Also, and maybe even more importantly, particularly people with autism, these individuals struggle generalizing things from one situation to another. So skills that you learn in a school setting may not generalize to a home setting. Skills you learn in a hospital setting may not generalize to an outpatient home or school setting. So even if you are making improvements with a hospitalization, that may not turn into improvements at home, at school, in day program, etc. So there are these challenges before we even talk about like the pros and cons of utilizing the hospital.
Well, and I think the biggest concern I have is seeing these folks then be separated from their families, separated from their educational programming, their vocational or job type setting, and any therapies that they may be involved in, or respite or community hab, those types of things. I mean, the individuals on the spectrum or other DD diagnoses typically respond super well to like structure and routine, and all of this is being disrupted. But I get families are in crisis and they're desperate and they have nowhere else to go. So when there's a safety concern,
yeah, absolutely. So it's all about risks and benefits, right?
Yeah.
It's all about is what we're getting out of a use of in the psychiatric emergency room or a psychiatric hospitalization. Are the benefits from that outweighing the risks of utilizing it? So just as you said, you will have lost connection potentially to natural supports and clinical supports. You may, if you're in the hospital for too long, lose your educational placement, lose access to respite and other things. So even though we may treat something that's important, the question is at what cost?
Yeah.
So let's talk a little bit about, what are legitimate reasons for utilizing a psychiatric emergency room or an inpatient hospitalization? So the first one, we've had numerous conversations during coffee talk talking about the importance of knowing diagnoses. So people with autism or other developmental disabilities have the same rates or occasionally higher rates of various psychiatric disorders, schizophrenia, major depression with psychotic features, bipolar disorder, catatonia, PTSD, all these things we've talked about in prior episodes. And sometimes the appropriate treatment location for that is an inpatient unit. So you have someone who is manic and psychotic. Yes, they have autism. Yes, they have an intellectual disability, but they're manic and psychotic and they're unsafe because of those things.
Mm-hmm.
It's a very reasonable use for a hospitalization.
Yeah, makes sense.
There are certain treatments, electroconvulsive therapy. We did an episode a couple episodes ago about catatonia, talking about high doses of things like Ativan or Klonopin that just may not be safe to do in a home environment. APEC primarily treats people in a group home, school environment, and we do it very successfully with very complex cases. But there's times when even Janelle and I will say, yeah, I think we need to put this person in the hospital because we can't do this safely because of other comorbidities or things like that. And then just as you alluded to before, safety concerns. Now let's be clear. If it is unsafe for the individual to be in the community or for the family or for the community because the individual poses risk to them, then sometimes we have to go to a psychiatric emergency room and sometimes we have to leave our loved one there.
Yeah.
That is a very legitimate use of a psychiatric emergency room or psychiatric hospitalization, but let's not confuse that with treatment. We're now simply doing this because things have gotten so unsafe in the community that we have no alternative.
It's not manageable and it's not safe.
It's the least worst alternative. And so I would never walk up to a family and say, you shouldn't have brought your child or loved one here. Safety concerns are huge with this population.
Yeah.
As we've talked about before, family members have exquisitely high rates of PTSD and things like that. And so it's fully understandable when we get to a point that the family capacity to maintain an individual in their home or in the community is just surpassed, and the hospital is the last stop.
Mm-hmm.
That doesn't mean we're using it for treatment, but it's a legitimate use. So those are reasons why it makes sense to us as the APEC team of when we're going to use a hospital. Whenever you're going to recommend a hospitalization, though, I will tell you it's going to be very, very important to think about a couple things. One, what are you hoping to gain from that inpatient stay? A lot of people will say, well, I want my child to be better. I want them to not be self-injurious or aggressive to others. I want them to function better. Those are lofty goals and important goals, but those are not measurable goals. It's one thing to say, my child is not sleeping all night. We think they're manic and we need to get their sleep back intact.
So something specific and time limited,
measurable, and also achievable within the typical length of stay of that inpatient unit. Most inpatient psychiatric units in this country have a length of stay less than 2 weeks, and in many places far less than 2 weeks.
Yeah.
So the concept of, I want my child, and I use child kind of globally, I want my loved one to be better. Well, is there something I can do in 7 to 10 days to improve that we can measure, that everyone's agreeable, the inpatient team, the family, the outpatient team, that things are better and therefore they can be discharged back home or back to a group home? Or is it more nebulous? Because if it's not clearly defined, you'll find that when we put someone in these very structured, intense, sensory overload environments, that the thing we put them in for may have gotten better, but the environment itself may have made a whole bunch of other things worse. And overall, you may have lost more than you gained. So there is reason to use a hospital, but they have to be very well defined. And if you want that hospital to participate with the outpatient treatment team and agree upon an admission, then there better be a discharge plan. And I don't mean, well, when they're better, we may be able to let them come home, or they may be able to go to a group home. I mean, we're going to admit them for 1 to 3 weeks. We're going to do these 2 or 3 things. When they're done, even if they're no better, they have a place to go. If that's not the case, I will tell you hospitals will be very hesitant to admit someone, because as we've talked about in other episodes, and certainly it takes 2 seconds on Google to see kids and adults who live in hospitals. I think my longest patient was 2.5 years. Our longest psychiatric emergency room stay was about 304 days. When I tell people this, their eyes get wide, their jaws drop. That is typical across the entire country.
Right.
So we want to be careful about that.
And just talking a little bit more about all of this, I mean, we tend to get families who come in with these myths of hospitalization. So I know we talk about, diagnoses and these other things, and can you do all of these things for us in a short period of time or a long period of time? Who knows? But talk about the myths, because these are super important in this population.
Yeah, there's a lot of reasons why hospitalization is detrimental to this population. We talk about, there's a phrase called iatrogenic causes of illness or morbidities, and that is unintended bad outcomes by doing something in treatment. One of the most common things would be we give people a bunch of medications for their behaviors, their aggression, their self-interest behaviors, but causes all these other side effects that may be worse than what the behaviors were. They're unintended bad outcomes. There's a lot of myths around hospitalization, and unfortunately a lot of myths that are perpetuated by people in the system of care. And I don't think they're doing it on purpose. They just really are uneducated about what happens inside a psychiatric hospital. So, first of all, we want someone hospitalized, or we're going to go to the psychiatric emergency room to get diagnosed. I can't say this any more strongly or plainly. Psychiatric emergency rooms, or emergency rooms in general, are not places to get a diagnosis. They're places where the team of providers determine, do you need to be admitted to the hospital, or are you safe for discharge? You will end up with a diagnosis on your discharge paperwork. That will very likely be based on a brief interaction with the emergency room provider, who may or may not have a lot of familiarity with people with developmental, intellectual disabilities or autism. And unfortunately, that paper trail will follow a family with all these diagnoses that they have this, and this.
Accurate or inaccurate?
Exactly, and quite often inaccurate. So diagnosis does not require inpatient hospitalization.
Right.
And as if people have watched our prior videos, they'll see that diagnosis for certain conditions can take days, weeks, months, or years, and that's in a neurotypical population. In this population, individuals who may not have expressive language skills, that can't tell us how they're feeling, who don't verbalize, so we can't see that their thought process is disorganized, it can take even longer. So while we can diagnose someone in an inpatient unit, that is not a particularly good reason to utilize one.
You're better off having someone assess all the different areas of that person's life and functioning in an outpatient setting.
Within the setting that they both live in and the one that they ultimately have to be successful in.
So what's another myth?
So another myth, the idea of a medication washout. Probably 3 or 4 times a month, someone refers someone to me and says, can you admit them to the hospital, take them off all of their medications, observe them for a period of time, and then reintroduce those medications or some other medications and measure and make certain that they are effective with less side effects. I would love that to happen. Janell and I have been incredibly successful at taking really complex cases, individuals who are on 6, 10, 12, 14 medications, slowly tapering them down, getting them down to 2, 3, or 4 medications with much higher levels of functioning, doing much better within community settings, group home settings, etc. That takes on average, 18 months to 2 years?
For sure, yeah.
There's no inpatient unit that replicates that other than state hospitals, which are few and far between and do not specialize in this population. So the concept of pulling someone off of meds, even if I take you off of all your meds right now, it may be weeks or months before the full effects of doing that manifest themselves within your body and your behaviors. it's a much more reasonable thing to do as an outpatient over time. I get not all communities have access to a program like ours where people come into the home and into the group home and do this treatment. And so maybe they have to utilize the hospital, but a med washout is just simply something that one will not happen. If it does happen, it will not happen effectively. And then even if it happens effectively, it will not necessarily generalize back into the community. So it's a reason, it's a really tough reason to justify a hospitalization.
It's a long hospitalization for something that's not going to necessarily have good outcomes.
Right.
And I know there's another large issue that we face when we have people referred to us for hospitalization, thinking that maybe they'll get quicker
placement or group home placement, yeah.
services.
So I guess this is, if there's going to be a take-home message that people watching this video got, and by people now, I'm talking about families, but sadly so, I'm talking about service providers and community case managers and care coordinators and people in the general system of care. There is this incredible, largely prevalent myth that if my loved one is in a hospital or a psychiatric emergency room, they will get a group home placement quicker. There's a couple flaws to that. First of all, group homes are not placements. You know, placement is going to a residential center for 6 months and going back home.
Yes.
Or going to a subacute rehab after a stroke. That's a placement. Even going to a nursing home temporarily. Group homes are forever homes. This is where we hope this individual will grow, develop, and live. It is a home. So goodness of fit between that individual's particular issues, strengths, and challenges, and that group home milieu are far more important than how quickly it happens, because we want someone to settle in and live their best lives in this residential setting if that's where they're going. You will certainly be put to the top of the list if you are living in a psychiatric emergency room. You'll be an emergency needs placement. You'll be essentially homeless.
Yes, yes.
That said, you will be at the top of that list with 100 to 1,000 other individuals vying for 5 to 10 group home placements over the next 3 to 5 months. And the very nature of being in the hospital will make you less desirable to agencies that run group homes.
And why is that?
Well, so first and foremost, there's only so many things you can do. Now, we're speaking primarily from a New York State point of view now, because that's where we practice, although we do consults all over the country. But when you're in a psychiatric emergency room or hospital, there's only so many things we can do. There's not 2-person standing wraps. There's not supines. There are mechanical restraints, and there are IM injections for people who are becoming aggressive or significantly self-injurious. And so on paper, you take an individual, let's say with autism, you put them in a sensory overloading environment with a staff that is not particularly well trained for this population, with a bunch of neurotypical individuals with schizophrenia and mania and PTSD and personality disorders and substance abuse and use disorders. And that person gets more escalated. And when group homes start looking at them after they've been in the hospital for 4 weeks, 4 months, 2 years, they start seeing behaviors and interventions that are inconsistent with what they can do. We can't do a 6-person restraint. We cannot give an injection of Haldol.
Right.
We cannot do these things.
Right.
Now, the reality of it is the only reason why this individual is getting those is because they're in an environment that's not appropriate for them.
Yes.
But on paper, it makes them look unserviceable in a group home setting.
It's an unfortunate reality.
So very often families are very shocked to hear this when we go in and say, I know you think this is going to improve your ability to get your child or loved one to a group home. It's actually going to delay the process maybe as much as 2 times as long as it would have been if you're an outpatient, at least, and maybe much longer. So I guess the take-home message, and to wrap up, is, you know, we've said this over and over again. Individuals with autism or intellectual developmental disabilities have the same right to have a psychiatric disorder that requires hospitalization as their neurotypical peers. And if a psychiatric hospitalization is indicated and used for those reasons, it's challenging this population, but it can be doable and it can make sense. But there are all these other complexities that go along with this, And in fact, utilizing an emergency room or a hospitalization for some of these other issues that we talked about not only will not benefit your loved one or the person that you're treating, but will quite possibly and quite frequently make their situation that much worse.
It could be detrimental.
So these things should always be thought of and considered before we start sending our loved ones or the people we treat to the emergency room or looking for a hospitalization.
And so I just want to end with, I think just the assessment and intervention at an early age is super important, to mitigate that risk of future hospitalization or ER presentations, and really uploading services and supports to the family. The more supports and services a family has, the less likely they're going to need, and be overwhelmed and need to access this level of care. So we wish you all well. We know it's a tough journey, but until next time,
APEC out.
APEC out.